Well, thank you very much for joining us for our afternoon sessions here. I'm Sarah Mowry. I'm hosting this session entitled Beyond Treatment, Quality of Life in Vestibular Schwannoma. As you guys know, there's lots of ways to treat vestibular schwannoma, but I think some of the things that are sometimes left out of that discussion are how do we help manage some of the sequelae from treatment. So we put together a great group of panelists here for you guys this afternoon, talking about some of the quality of life issues that these patients experience. I'm going to go ahead and invite our first speaker, Dr. Matt Carlson from Mayo at Rochester. Mayo Clinic. He's a professor of otolaryngology and neurosurgery. And Matt's going to give us an overview of sort of quality of life in these patients and some of the work that he and his colleagues at Mayo have done around this. So, Dr. Carlson.
Dr. Mowry, thanks a lot for the opportunity, and also ANS. So I think some of our speakers are going to be talking about different aspects for rehabilitation to improve quality of life. I'm going to talk more about how treatment may or may not impact and other predictors of determinants or other determinants of quality of life. I don't have any relevant disclosures. There's a lot of controversy surrounding what is the best management for vestibular schwannoma. There's a lot of antiquated beliefs about what is the best treatment and what isn't, and I think a lot of it isn't really rooted in evidence. There's a lot of strong opinions, but there's no evidence to suggest one treatment is the penultimate or best treatment, and we'll go into some of that in this talk. So historically, in the early 1900s, our attention was turned towards mortality reduction. With EMG introduction in the early 1980s, it gravitated towards facial nerve outcomes and more recently hearing outcomes. But particularly within the last 15, 20 years, there's been increasing evidence placed on quality of life. We all know that for tumors less than about 1.5 centimeters or 2 centimeters, there's really 3 reasonable management options: initial observation, radiosurgery, and microsurgery. And each individual treatment might give one particular patient a very good outcome. Of course, the answer's in the crystal ball, and we can't always predict what treatment will give each individual patient a better outcome. So the purpose of this is to talk about which treatment might give the patient a better outcome with regard to a particular feature that they might have, a demographic feature, baseline symptom. So we've all been in this situation where we're seeing our patient back post-operatively, say they're coming in 3 months post-op, and before you go in the room, you look at the audiogram and you're really excited. You saved hearing close to baseline level. You look at the MRI and it's very clean, so you had a gross total resection, and you expect to walk in the room and have the patient very excited, and you're high-fiving your neurosurgery colleague, and you walk in the room and you only find out that the patient is really significantly bothered by other things that you have a hard time controlling with your treatment, but significantly impact a patient's quality of life, things that are also oftentimes very difficult to rehabilitate. And these less tangible features and often difficult to quantify features may be significantly disabling for the patient and affecting their well-being, personal life, vocation, etc. Over the years, we've seen an increase in number of increasing attention placed on quality of life in the general medical literature, but also in the vestibular schwannoma literature. But despite this, we still continue to, our literature really still focuses on hearing, facial nerve outcomes, and really less attention is given to these other factors that might significantly impact patient well-being. Historically, the SF-36 and the Glasgow Benefit Inventory were the 2 measures used to evaluate quality of life. These are generic measures and really don't speak to a lot of the symptoms or conditions that a patient with a vestibular schwannoma might encounter through their treatment course. And so fortunately, Dr. Ruckenstein and his group at Penn came up with the Penn Acoustic Neuroma Quality of Life Index in circa 2010, which is the first and only thus far disease-specific measure to evaluate quality of life outcomes in sporadic vestibular schwannoma. So the first part of this talk is to look at what are the primary determinants of quality of life outcome for patients with sporadic vestibular schwannomas. Is it patient age, tumor size, presence of tinnitus, dizziness, facial nerve outcome, etc.? To answer this question, we performed a large cross-sectional study with our colleagues in Bergen, Norway, and we surveyed a very large population of people who were treated with singly treated with either initial observation, microsurgery, or radiosurgery, and they all had smaller tumors, so nothing over 3 centimeters. And we evaluated their quality of life measures approximately 7 years after their initial treatment course or diagnosis if they were being observed during that whole time. and we evaluated them using the PanQual SF36 and also a homegrown vestibular schwannoma symptom questionnaire. We correlated or drew associations between baseline demographic features, tumor features, and presence of symptoms after treatment to see what associations existed and determine if there were a specific feature that predicted their overall quality of life. In addition to looking at primary determinants of quality of life, we took a deeper dive in two specific areas, dizziness and headache, that in a minute you'll see were primary determinants of quality of life deterioration. If we looked at our patient demographic in the study, we had approximately 550 patients that were treated on average 7.7 years earlier from the date of survey. We have the expected demographic for the population in that they're men and women represented about equally. And the age demographic at time of treatment was mid-50s. At time of survey was early 60s. Good range of tumor size. We had all three treatment modalities represented. Most patients had poor hearing, and most patients had normal facial nerve function, which is pretty representative of patients after a treatment course if you take a large group of people. And then we also looked at some of their subjective symptoms and what they had at the time, the frequency and the severity of the different symptoms. And you can see also a range of reported subjective complaints, which is important when you're trying to draw associations. So a couple things. So these are associations between patient features like hearing status, age, frequency and severity of tinnitus, frequency and severity of dizziness and headache over time with the PanQual. So the PanQual is a 100-point scale that includes 7 domains. So 100 is the best quality of life, 0 is the worst quality of life. An average outcome for most studies put a person around 60 to 80 for quality of life, just for reference. So these are parameter estimates, meaning you can look at the reference group for the baseline, and you can look at increasing worse, if you have a worse symptom, how much that impacts your overall score. So in this, what we found to be highly statistically significant and also clinically significant was deterioration in quality of life if you had bad dizziness or frequent dizziness and bad headache or frequent headache. Meaning if you had bad dizziness compared to somebody who didn't have bad dizziness, your score dropped 25 points, which is a really large drop when you're talking about a 100-point scale. This is basically a different way to look at it. The last slide was parameter estimate, so it told you how much your score dropped compared to a reference group. This is just the raw score, so it's just another way to repeat the data that I just presented on the previous slide. The story is the same. Headache and dizziness are the primary drivers. When present, they predict the greatest deterioration in quality of life. And this is a continuation of the story. It looks at SF36 physical component outcomes and SF36 mental component outcomes. And even for a less sensitive measure, the SF36, we still found that those two features primarily drove quality of life. And when you're using a less sensitive measure, if you can still see the effect, it's probably a pretty significant effect, which is what we believe to be true. So now if we take a deeper dive in the two areas that we just talked about, dizziness and headache, a little bit more. We did post hoc analysis on that initial data set, and we looked at these features, and specifically, we looked at people with really bad headache, and we looked at people with who had bad dizziness. And we tried to look at those two groups a little bit more closely. If you think about the vestibular schwannoma, if you read about vestibular schwannoma textbook, you'll always hear retrosigmoid craniotomy causes the worst headache, and if you have retrosigmoid craniotomy, you're going to have a bad headache, bad quality of life. If you actually look at our data, a long-term follow-up, there's no difference in treatment modality, meaning people were at a heightened risk for having bad headache 7 or 8 years following treatment compared to even radiosurgery or observation. I think, of course, we'd all believe in the very short term that's true. Immediately post-op, you're much more likely to have a headache than you are a day after radiosurgery observation. But long-term, it becomes a wash. And actually, the strongest predictors are patient age, so younger age, presence of anxiety or depression, and pre-existing headaches were the primary drivers. And our treatment actually doesn't modify the patient's baseline symptoms much, surprisingly, which I think is against what we believe, what we have heard all these years. And we look at dizziness. The strongest predictors were being a woman, being older age, having a larger tumor size, pre-existing dizziness, and pre-existing headaches. So if you're dizzy before treatment, you're more likely to be dizzy after treatment, regardless of what treatment modality you use. So what offers the best quality of life overall? We compared, in that same cohort, we compared quality of life outcome differences between the three singly treated patient groups, observation, microsurgery, and radiosurgery. We also compared them to a non-tumor control group. And here is that data. You can see just a couple things I want you to draw from this. First of all, to have the best quality of life on the PanQual, it's best to not have a tumor to begin with. So non-tumor controls had the best quality of life overall. But I also want to point out that the differences between radiosurgery, microsurgery, and observation are quite small when you look at these graphs, probably much less than we would have thought. And then furthermore, probably most importantly, is not just looking at statistical significance on a 100-point scale. If you have a large population of patients, you have a 100-point scale, even a 3-point difference can become statistically significant, but probably not clinically meaningful. And so we developed MCID estimates for the PanQual, which basically, if you want a good rule of thumb, it's about 8 to 10. You need about 8 to 10 points different to be clinically significantly meaningful for the difference. And when you look at these scores through the lens of the MCID, actually, treatment is a large wash with regard to quality of life. That data was all from a cross-sectional study. And of course, one of the limitations of cross-sectional study is it's not longitudinal or prospective. And so you don't have your baseline scores. You can't tell how a person does before and after treatment. There might have been selection bias that might influence your cohort. And so we also looked at this prospectively and found very similar outcomes. But I do want to point out one or two very interesting things. Even though if you look at the bottom line, at the bottom box, you can see the quality of life differences prospectively, the change among the three treatment groups was not statistically significantly different. But I do want to point out one thing in particular, and that's the surgery group. There's a small proportion of people that embark on having surgery, even if they qualify for radiosurgery or observation, simply because they have significant anxiety over having a tumor in their head, and they might be relieved of some level of anxiety by having that tumor removed from their head with surgery. Of course, surgery is the only what we would call physical cure where the tumor is actually removed. And so with the surgery group, providing surgery actually was the only arm of treatment that provided a significant improvement in any of these domains. Along the lines of the idea of having anxiety over having a tumor in your head, if you just looked at all the groups, you'd say, well, observation, microsurgery, and radiosurgery are about the same. But I want to draw additional attention to the newly diagnosed patient. So if you've been diagnosed and have had your diagnosis for less than 6 months, we called this the indeterminate group. They don't know which pathway they're going to go for sure, and they just had their diagnosis. And what's really remarkable in this group is that in that group, the largest or the poorest quality of life with regard to anxiety is specifically in the newly diagnosed groups. And so there's probably a lot of quality of life reduction in that initial time of diagnosis when you just heard you have a brain tumor, which a lot of people associate with neurological incapacitation or even death, which of course is not the story for a benign vestibular schwannoma, but that's what a lot of patients think of when they first get the diagnosis. If you continue to follow them a little bit, that anxiety is relieved. It's 6 months afterwards, they've got their repeat scan, or a year, depending on what your practice is, and the tumor hasn't grown, and which can be a relief for patients. We're running out of time here, but just a couple things. I want to point out that if you, this is just a report of symptoms on a VAS, so it's not using a validated measure, but the findings are pretty similar. What's interestingly is we saw a bidirectional effect with headaches with regard to treatment. So surgery did have a slightly higher risk of causing headache long-term, but it also had a slightly higher ability to improve headache long-term. And this was not accounted for people with large tumors and trigeminal neuralgia and hydrocephalus. Even in the smaller tumor population, it held true. So interestingly, you could go either better or worse with that. So in conclusion, patient-related factors rather than treatment modality most significantly influence quality of life. Dizziness and headache are relatively uncommon, but when present, they cause the greatest reduction in quality of life. Tumor size, patient demographics, facial paralysis, hearing loss, and tinnitus may impact quality of life, but to a lesser degree. Thank you very much.
Dr. Carlson, thank you so much. That was great. You guys have done really interesting work looking at large groups of people, and I think that really helps inform our ability to counsel patients. So next up, we're going to dive a little bit deeper into some very specific issues that patients are dealing with post-op in their rehab or post-therapy in their rehab. And so I'd like to introduce Dr. Maya Shrekich, Associate Professor at Hofstra University and at Northwell Health in New York. And she's going to talk a little bit more specifically around hearing loss and how it affects patients' quality of life with their vestibular schwannomas. Dr. Shrekich?
Great. Thank you for having me, Dr. Mowry. And no introductions needed. She did a great job, and I'll just dive right in. So as Dr. Carlson pointed out, age, sex, treatment modality, and tumor size do not significantly affect quality of life. However, dizziness and headache seem to be the key drivers of poor quality of life. And so where does hearing loss come in that scale? It's sort of in the second tier of predictors, so facial weakness, tinnitus, and hearing loss, where hearing loss seems to be the smallest contributor to overall decline. So this is a case example I'd like to show you. This was an 85-year-old woman who just a couple weeks ago presented to my office with a sudden right-sided hearing loss. She does not wear hearing aids, and her issue right now is that, well, 3 days ago she was participating in family conversations as an active had an active social life. Suddenly she couldn't do so anymore. And so when I conducted a hearing test, I could see that she does have some bilateral sensorineural hearing loss, but as you can see, the thresholds don't differ so much between the left and the right side. However, the speech discrimination is significantly worse on the left, with only about 12% remaining. The thing that's contributing to her quality of life drop is the type C tympanogram on the right ear. And so when you look at this MRI, which of course I was surprised to see that she had as a medium-sized schwannoma on the left side, but that's not what's affecting her quality of life. It's really the loss of hearing in that good ear and the sudden loss of hearing. So when we're talking about sort of the objective and subjective measures, we've all seen these before. These are the objective measures of hearing loss that we pick up from an audiogram. And traditionally and typically, we sort of group patients into aidable and unaidable categories, thinking that there's a significant difference between classes A and B and classes C and D. But when we look at more of the sort of subjective measures, and again, thank you, Dr. Carlson, for providing all of this data for me. My job is easy. They did a nice study really looking into the hearing loss and quality of life in vestibular schwannomas, and here I will summarize some of those results. They had a good spread of patients within all hearing loss categories. And the two important questions that they asked regarding quality of life was exactly what my patient complained about. And it is how it is affecting their personal sort of relationships, and also how it is affecting their ability to participate in conversation. In addition to those quality of life questions, the survey also asked patients to talk about sort of and rate their own level of disability and hearing loss. And so this is where the data becomes granular and interesting. When it comes to the relationships question, how hearing loss has affected those patients, if you look to the area where we have speech discrimination scores, the range of those speech discrimination scores is surprisingly so, for example, for people who agree to that statement, between 0 and 74%. So even patients who have a very good speech discrimination score, 74%, would say that hearing loss has affected their personal relationships. Similarly, when we look at the next predictor of quality of life, or the next question, which is how it's affected their conversation, again, you can see this very wide spread of word recognition scores in all these different categories. And for patients who do agree that hearing loss has affected how they carry on a conversation, you can see it's a 0 to 84% spread. So even people with a category A hearing are going to have a significant impact on their quality of life. So basically what we've learned from this study is that subjectively categories B and C are not different. And that's sort of how they cluster in this diagram. On the bottom left, you see class A hearing. Top right, you see class D hearing. The B and C are statistically not very different. And so for patients, it doesn't matter that the artificial sort of aidable, non-aidable, for them, B and C tend to be similarly disabling. So what do patients notice? And this is sort of what I see in my practice. The 30 decibel rule, if one ear is worse than the other by about 30 decibels, they will definitely notice that. And if it's 40, 50, 60, that really difference doesn't matter. They will definitely notice a rapid decline or a sudden decline. If there's any effect on the better hearing ear, they'll notice that. And then when you otherwise have very good hearing, even small changes will make a difference. And let's look at some of the examples for that. So here's a patient, a 72-year-old man who's just being followed, standard follow-up for his vestibular schwannoma. You can see the top and the bottom hearing test, a year separated. At the top, he had a 60% speech discrimination, which basically progressed to no speech discrimination a year later. he didn't notice a difference in his quality of life. He basically just came for surveillance. Another sort of dogma that we now know is that the size of tumor does not consistently predict the degree of hearing loss, but also that the higher degree of hearing loss does not always consistently predict worse quality of life. Another case example, this is what happens when you have extremely good hearing. So this is a 24-year-old woman with wonderful hearing. She does have a small 5 decibel difference in the left ear. No one would even scan her for this, but because of this persistent symptom, she did end up getting some form of imaging. And you can see a very large tumor, almost no effect on hearing, but it did have an effect on her quality of life, even that 5 decibel difference. On another patient who, this is a heavily weighted T2 sequence, but you can kind of see the tumor. It's very large. This patient is a very large tumor, a very small effect on hearing. She's still in her grade A hearing at both grade A hearing on both ears. Next patient, a 46-year-old man, tiny tumor, but it's intracochlear, so it's causing a lot of problems. He presented with a sudden loss of hearing. We can only presume that his hearing before presentation was excellent, just like his left ear. And here he is with a small tumor and a very large deficit very quickly. So clearly he's coming to us quickly as well. So these are the take-home messages from some of these cases and also from Dr. Carlson's study. But objective hearing loss required to precipitate meaningful disability from the patient's perspective is considerably more subtle. Speech discrimination scores provide a more reliable indicator of subjective hearing loss and a better predictor of unfavorable quality of life, more so than pure tone averages. A decline in these scores to less than 75%, and again, that's less than an A category, is likely to result in disability. And this is sort of, I think, where we can come in and make a difference in counseling. But there is such a poor compliance with hearing aids, even in patients who said that they were had a high prevalence of hearing loss subjectively. So I think this should inform sort of how we take our history and counsel patients. We should definitely discuss the prognosis of hearing loss with either treatment modality. I think that's one of the most important things. I usually, when patients present with hearing loss, say this is the worst that's going to happen with this tumor. Again, typically. We should talk about sort of what affects the quality of life for most patients. The patients may have their own sort of quality of life issues. However, it's important to tell them what most patients will subjectively feel. And so I think this sort of normalizes the experience for them. We should assess their functional status, whether they're using a phone, hearing aid, and their subjective severity level, and then some of these important quality of life questions. So most importantly, the ability to participate in conversation and the effect the hearing loss has in their social life. But we should also ask about associated symptoms, which we know are poor predictors or predictors of poor quality of life: headache, dizziness, and tinnitus. When it comes to sort of the prognosis and stability of hearing, some of the factors are listed, but age and noise exposure and any planned interventions should also be discussed. We should also assess barriers to rehabilitation and discuss the risks of no rehabilitation. So I think this is important. A lot of the patients are resistant to hearing aids, as we saw in that data. And so I think it's important to understand why. Some of the things to consider is cosmesis in patients, their professional and personal needs, their MRI needs, their insurance and financial support, social support, their perceived stigma. And then also we should discuss risks for no rehabilitation, certainly an increase in the incidence of dementia and even a decrease in the longevity. This is a very poor photograph of an excellent slide, but it tells you a little bit about sort of what the survival rate of available hearing is with everything, whether we do something or don't do anything to these vestibular schwannomas. And this is sort of what I tell patients: in about 10 years, you will not have usable hearing. And I think that's something that we need to really make sure we explain to our patients. I have to say, in my neck of the woods, neurosurgeons are not on board with this kind of counseling. When it comes to the scope of hearing rehabilitation options, when patients say, is there anything you can do to save my hearing? There's really a range of no intervention and some behavioral changes, even some medical treatments, and then some implantable devices. And then, of course, there are some hearing sparing interventions with radiation and surgery. There was a chart that I made a while ago. I did an updated with the newest sort of single-sided deafness cochlear implant. guidelines, but what's important, I think, to have in our armamentarium when we counsel patients is to think about all the different combinations. Patients with a vestibular schwannoma, where the hearing is normal, aidable, and non-aidable, and then patients with what's going on with the contralateral ear and sort of what sort of devices will be available. And so non-surgical hearing rehabilitation devices, these are your hearing aids, bone conducting hearing devices, and also over-the-counter devices. And I also tell patients you can use your phone as a hearing aid. You can use the microphone feature on your phone, put it on a board meeting, and then you can put a little AirPod into your ear, and that's your hearing aid. Also important is to talk about the surgical hearing rehabilitation devices, and these are your cochlear implants, auditory brainstem implants, and bone conducting devices. So again, these are some things to consider. I'll just briefly show you these cases, but this is a 57-year-old man with a sudden hearing loss on the right side, and surprisingly, the MRI shows a very small vestibular schwannoma, but close to the cochlea on the left side. So when you're rehabilitating that right ear, you have to understand that the left ear is the one that has a threatened hearing loss, and that rehabilitating that right ear will have the highest impact on his quality of life. This next case is a patient who's 42 with rather large tumor on the right side, but he continues to be a construction worker, and so you can already see some of those noise effects on his left ear, and that's also important to know as far as his prognosis and understanding that preserving that hearing on the left is going to really impact his quality of life, even though the tumor is contralateral. A 67-year-old man with left ear fullness and hearing loss. The hearing loss is significant on the left with a poor speech discrimination score. I think it's in the 60s, but maybe a little small here to show you that, a relatively small tumor. And then you have this patient here. This is an NF2 patient. You'll see this. She's 24. She has okay to good hearing on the right and left. But what's important to understand here is that her quality of life will not be dictated by hearing loss. Her quality of life will be dictated by other cranial nerve neuropathies and brainstem compression. So again, it's not all about the hearing loss. And then last, this is a patient who presented not with hearing loss, but with dizziness. Her hearing is within range. She does maybe have some early onset presbycusis on both sides, but you can see she has a vestibular schwannoma. But importantly, she has this dizziness. And so this is basically where we need to talk about the issues of quality of life. And I'd like to thank everyone. This is a complete dad joke that literally my dad enacted for me as I was making these slides. And that's, and that's my child with a perfect ear. So that's all I got for today.
Awesome. Thank you so much, Dr. Shrekich. I think we could do like a whole hour and just discuss those cases that you had at the end. I mean, they're all not straightforward, not easy management issues. And I think that really speaks to how we counsel our patients when they come in with some of these issues. Thank you so much. So it's my pleasure next to introduce Dr. Teresa O. She's also an associate professor at Hofstra University. So we have a New York theme going on today, but she's going to talk to us a little bit about one of sort of the most feared and devastating complications that some of our patients experience, which is facial nerve, either paresis or paralysis after treatment, whether that's radiosurgery. Sometimes patients come in with facial paralysis as one of their initial presenting complaints, although that's certainly rare. And then, of course, after microsurgical intervention. So, Dr. O, thank you so much.
Thank you, Sarah. Thank you for having me contribute to your panel. Unlike vestibular schwannoma surgery, which is deep in the temporal bone, facial paralysis is very visible and it can significantly impact quality of life. Why is a smile so important? Well, Ron Goodman, in a now famous TED Talk about smiling, speaks about the smile feedback loop. You smile, you get increased dopamine in the brain, you look good, you feel good. Others see you smile, and they also get flashes of dopamine and feel good. And so this goes on. And what's the social penalty for patients who can't smile? Well, they have significant anxiety and depression, and this correlates with the severity of paralysis. They have impaired communication, and we as observers see them negatively. They're seen as less attractive, as less normal, less trustworthy, and surprisingly also less intelligent. So our goals for these patients after or before vestibular schwannoma surgery are to improve and restore their appearance and smile, to guard and protect that existing facial musculature from any further injury, and to remember that just as there is a golden hour for stroke, for brain, for cardiac muscle, there's also a golden timeline for the facial musculature, and we need to think about that timeline to preserve it. Our principles to think about are that the facial nucleus and nerve is very unique and sophisticated, as is the facial musculature. Let's think about also the clinical presentation of the palsy, how long it's been present, and that'll determine our intervention. So this patient has a complete reversible facial palsy. This patient also could have a complete irreversible facial palsy. Here's an example of a mixed picture with a little bit of weakness of the right eye and the right oral commissure, and another presentation of abnormal reinnervation, such as synkinesis. In each of these cases, we'll use a multimodal, multidisciplinary approach with medical therapy, such as neuromuscular retraining, and a variety of surgical options, which I'll describe. If the distal facial nerve and facial musculature is intact, then we have an option to use other nerve grafts in their place. For example, we can use the contralateral facial nerve using a cross-face graft. This will give us spontaneity and tone. We can use the ipsilateral trigeminal nerve, such as the nerve to masseter. This will give us early excursion and powerful smile, but may not give us tone. Another option is the ipsilateral hypoglossal nerve, which will also give us excellent resting tone. Here's a comparison of nerve counts, and you can see just how powerful that hypoglossal nerve is at 120 times the number of axons, which is why we just use 30% of it, and as well the nerve to masseter compared to the ipsilateral buccal. In a case where there's a small segment of nerve missing, we can place an interposition graft from facial to facial, and this will give us could give us really good recovery within a year. One of the first widely described reinnervation procedures is the hypoglossal to facial. Previously, it was used in its entirety, and now we just take a 30% of it to give us good tone. Another nearby nerve is the trigeminal or the fifth cranial nerve to 7, and here we can harvest either the deep temporal or the nerve to masseter. This is an example of a partially reversible palsy. This patient had a slow weakness of the right midface and right eye over 6 to 7 months by the time he presented to me. He had been previously diagnosed with Bell's palsy. He had a geniculate ganglion venous malformation, and in the meantime, we placed a 5-7 in order to just keep those facial muscles stimulated. He then proceeded to surgical excision, and the nerve was left partially intact. He immediately had a flaccid facial palsy and recovered with tone and also with smile. A case of a parotid carcinoma with infraauricular spread and a spread along the facial nerve. We were able to remove with a radical resection and reconstruct with an interposition graft from the facial to the facial, as well as place a smile branch from masseter to facial. And here she is 1 year out. Another patient with polycranial neuropathy had a, the fifth nerve was no longer available to us. Therefore, we did a 12-7, a cross face to the smile branch using the medial antebrachial cutaneous nerve. And we've also started doing a lot more sensory reinnervation from V2 to V2. And here's the patient 2 years out. So after total or near total resection of a vestibular schwannoma, the nerve is still in continuity, How long do we wait for recovery? Well, the current status quo is to wait for 12 months. That's sort of what I always hear. What patients come, I'm going to come back after 1 year. So the group at Hopkins, Dr. Bohini, looked at this question. They studied 62 patients with CPA tumor excision. All the patients with no clinical recovery at 6 months were offered intervention. The ones who chose surgery were found to have no AMG responses with direct stimulation and were therefore given either a 12/7 or a 5/7 nerve graft. 8 patients who had no recovery at 6 months and had declined surgery further had no recovery at 18 months and stayed at a house Brackman of 5 of 6 or 6 of 6. So what do we get from this study? Sorry, I'm pressing the wrong address. That 6 months is a good timeline. If the patient has no preoperative normal facial function and no change in the house Brackman scale of at least 1 level within 6 months, proceed to nerve substitution. If there's any preoperative weakness, intervene even earlier. And so they've rewritten this rule that let's not always wait for 1 year. Here's an example of a woman with flaccid facial palsy. And at 6 months, she came to me at 8 months and she was still very flaccid. So we proceeded with a 5/7 to give her some smile. She did ultimately have some recovery of tone in the rest of the face as well. Another patient with a 2-year history of slow progressive facial weakness. He had a vestibular schwannoma and was deemed not a surgical candidate. When he presented, he stated that his face completely went out just 6 months prior. So that's why we proceeded to nerve grafts, 12/7, 5/7, and also a cross-face 7 to give him some spontaneity of smile. And here he is after 1 year after the procedures, as well with periocular rehabilitation too. This woman presented 1 year after surgical resection of vestibular schwannoma. She said that there was some residual disease that was left in place, and she had serial MRIs for observation. In that 6 to 12 months, she recurred, and the tumor was growing larger and larger, and therefore she was offered either gamma radiation or surgery. She elected to do surgery knowing that the nerve would be very fragile at this time. We therefore did a 5 to 7, and so she had the facial muscular protected in this time. And at the surgery, she also underwent a 12/7 because the nerve at that point was sacrificed. So in the cases of clinically irreversible facial palsy, meaning that the facial musculature is no longer intact or it's denervated, we can proceed with static slings, local temporalis transfer, or free muscle transfer using 1 or 2 stages. The go-to muscle for facial reanimation is gracilis. It can be done in a 2-team approach, and it is great shape, good anatomy, and most recently, it can be divided into many vectors because it's chimeric. In a 2-stage approach, we would first perform an endoscopic nerve transfer. This was first described by Hadlock et al., and we can get a really long length of nerve with just a very small incision behind the ankle. Nine to 12 months later, we would then proceed with the muscle transfer to that sural nerve graft. And here's an example. You see the mid-face flaccid palsy and after 2-stage reanimation. Another example of right mid-face palsy after 2-stage reanimation and also some jaw augmentation. This child had a posterior fossa tumor which was resected with fully flaccid facial palsy of many years. He therefore underwent a 2-stage procedure using sural nerve and gracilis, and here he is after. We can also apply this for bilateral facial palsy from Mobius or iatrogenic causes in this case, using nerve to masseter as our nerve. Bohini et al. Further modified the gracilis into a multivector because in some patients you get a lot of medial dental show, and this allows you to do it. We can split the vector, we can split the muscle into two components, an anterior and posterior. And this, for example, in this girl, she had a lot of dental display, and she certainly benefited from this approach. Here, abnormal reinnervation with the hypertonic situation. We can use Botox, myectomies, neurectomies, and of course, neuromuscular retraining. This is an example where I use neurectomies. I've isolated all the facial nerves, stimulated each and every branch, and taken the branches that are giving me negative pull that are not going to contribute to a good smile. So this is an example of a neurectomy with a contralateral facelift. Another example, left synkinesis with relaxation. We can zip forward. Another example with some relaxation of that left face. And myectomies, where we actually target the muscle directly, the orbicularis, the DAO, and the platysma. And improving quality of life by also adding sensory reinnervation for the cornea and for the face and the various areas. So in summary, facial reanimation after vestibular schwannoma surgery depends on the status of the nerve at the time, the facial musculature, the duration of the palsy. We need to recognize that there's a golden timeline, that time is muscle, and therefore timing of intervention is critical. So we would also encourage early referral. Thank you very much.
Dr. O, thank you so much. My husband, who's a cardiologist, would also agree with you, the time is muscle. So great pictures, awesome results. Thank you so much. We're going to turn next to Dr. Ben Crane, who's a professor at the University of Rochester. And I asked Dr. Crane specifically to come on and talk a little bit about his understanding of how or why these patients continue to have vestibular issues even after we've done treatment for them, whether that's microsurgical excision or radiosurgery. Dr. Crane, I'm going to let you take it away because you have some really great pictures in your talk.
Thanks. Yeah. Thanks, Sarah. Thanks for inviting me. So I didn't meet any disclosures that had to be disclosed. I do have a patent on a device that's not licensed that I will talk about. So I wanted to start with a case report. I click next. Oh, there we go. There's the case report. So this is a patient I had that saw me in clinic. You can see there's a small acoustic neuroma here, about 1 centimeter. During the visit, she was very concerned about hearing preservation because she had some hearing and had seen a number of surgeons to discuss what her chances of hearing preservation were. I ended up with the case, did the case, saw her the next morning and asked how she was doing, and she said she was doing awful. In fact, she wished she was dead. And I wondered what the problem was. And we'd actually been able to preserve hearing. And the problem was that she'd been vomiting and she felt like she was spinning and she had the most awful vertigo. And the reason for that was because she had pretty normal vestibular function prior to the case, which was then lost afterwards. And what happens in these cases is we know the vestibular physiology, at least of the canal system, fairly well. A bucket of water, you can rotate the bucket and the water will tend to stay in about the same place. And the same principle kind of affects our semicircular canal system. So when we rotate our ears, the ampulla will then experience pressure differences on each side. And then that's encoded by a difference in firing rate in these neurons. And the vestibular system, or at least the horizontal canals, are fairly unique in that, you know, no stimulus doesn't necessarily mean there's nothing, but looking at the symmetry between the two sides. So as we rotate, one side increases and the other side decreases, and our brain interprets that as returning. When we do surgery, such as this patient, we have kind of balanced function at the beginning, and then suddenly when we lose function, then there's no function on one side, and because all the activity is coming from one side, the brain interprets that as that you know, we must be spinning, and you'll see an nystagmus with that as well. Now, also happening at the same time as we have the otoliths, So these essentially accelerometers in the ear, the utricle and the saccule. And there hasn't been as much work known on these. Now, of course, it's well known that after we take these patients will often have a subjective offset in vertical. And this is a patient of my former mentor, the late John DeParco, who had an acoustic neuroma removed. And afterwards, she had a view of the dome there at Johns Hopkins. And her hobby was painting these little paintings on matchboxes. And she painted this picture for him. And you can see here that the dome is tilted there. And there's been a lot of testing that's also demonstrated these types of effects. But the clinical significance isn't clear. However, I think the clinical significance is actually pretty significant. So here in Rochester, we have a children's museum, the Strong Museum of Play, where they have this vertigo room. So as you can see here, the vertigo room is a room that's tilted about 20 degrees. And if you go in the vertigo room, and here's my daughter in the vertigo room. It looks like in this picture like it's a pretty normal room, but you feel very off in there because what your vision's telling you and what your inner ear is telling you is very different. And so when she stands up straight, it actually looks like she's standing at an angle. And when I talk to these patients who have done acoustic neuroma surgery, and they'll sometimes come back 2, 3 months, 6 months later, and they're still not back at work, and I ask them why, and they still feel very fatigued. They describe dizziness, not really spinning, and I think some of these types of effects might be what they're experiencing, where things just continue to be off and they haven't recovered from that. So I also hadn't been looked at as much, and we started looking at it in our lab recently, as I thought, well, maybe the other part of the otolith system, the utricular function that senses our motion through space, is also off. And so we could do psychophysics experiments by basically putting people who had loss of unilateral function on a motion platform and moving them, and then we can change their heading so it's more often in one direction and often the other, and then ask them by pushing a button if they move to the left or to the right. And there is no button for moving straight ahead. So in that situation, they just guess, and it's either left or right. And so because of that, what we'll see is then as we plot this, you see they're about 50-50 there, and we can fit a psychometric function to that. And that's what I'm going to show you. So normal function would be that it's centered in the center and a fairly narrow band around that. Now, when we look at, here's a patient that I did a labyrinthectomy, and I imagined to come in for testing 1 week afterwards. And she described that she was spinning, and I was trying to get at, the heading perception, and she wasn't even really able to do the task because she always, as you can see here, she always answers to the right, or almost always. And that's because she feels like she's spinning to the right. And so in that patient, I couldn't really do the heading task. But in these patients who you see acutely, usually that feeling of spinning will go away. If not in the first week, then certainly within a few weeks, especially if you do some vestibular rehabilitation exercises. And so I got many of my patients, many who didn't have any balanced symptoms. I've had over a dozen of these people come in now to the lab. And even like this individual, 15 years after a labyrinthectomy, didn't have any real symptoms. But when we did this task, he was deviated. His point of subjective equality was deviated over to the side. So I had to move him off to the right quite a bit for him to think he was going straight ahead. Straight ahead here, he thought he was always moving to the left. So essentially his feeling of where straight ahead was shifted about 11 degrees towards the side of the lesion. And this was actually a pretty consistent finding over a large number of people. So acutely, we have this feeling of spinning, especially if they had vestibular function immediately before the tumor was removed. And chronically, that vestibular function is then deviated when you do more of an otolith test. And my question is, maybe some of these people with long-standing disease have problems due to that. So for the second part of the talk, I wanted to talk about kind of some strategies for rehabilitating these. So we all treat these people with promethazine and meclizine and things acutely. It's just a sedative. It probably doesn't make them functional any faster. It may make them a little more comfortable, but it may also delay recovery. We don't have any surgical treatment to improve vestibular function yet. I'm aware of the studies that have been going on for the vestibular implant, really for unilateral function or dysfunction in this case. That kind of option is going to be a long way off. And finally, vestibular therapy, which is what which is known to be effective. But what is vestibular therapy? Well, there's a number of things that are done, and oftentimes a single program will include many of these. We can do adaptations such as gaze stabilization exercises, balance or gait exercises, habituation, sensory substitution, just education, relaxation and meditation techniques, as well as the Epley maneuver, which is obviously only appropriate for benign paroxysmal positional vertigo. The problems with the vestibular therapy is it's not clear from the literature what to do. Most of the studies have included a large number of techniques. Access to appropriate vestibular therapy can be poor. In a lot of centers, there's not people who have appropriate training. There's transportation and financial limitations for a lot of patients. And and it's unclear often what exercises to do. And so we give them many exercises, but compliance with these is probably poor. So what usually happens is they're given a handout, and this is a handout that used to be used in our clinic here. It gives a large number of exercises to do. I don't think a lot of these are ever actually done. We know for medication trials, the more times a day you tell people to take something, the less likely they are to do it. Some of these patients probably spontaneously improve, but there's also some that have long-term disability. And why is this? With this next slide, I wanted to review kind of some of the studies on vestibular therapy. So I'm going to look here at studies that look at people with chronic problems. So these are the people who at least 3 months afterwards still have symptoms. So they failed to improve in 3 months. So they've gotten rid of the spontaneous improvement factor for a large part. There's a few types of studies here. So first of all, I would like to point out that all of these show us a statistically significant improvement. But not all of them show a clinically significant improvement, which probably requires a change in dizziness handicap inventory of 22 points or 42%. So when they work with a physical therapist, which is the studies in yellow, even though these are only 4 or 2 week programs, all of them improved. When they did the exercises on their own, which is the ones in blue, which are between 12 and 8 week programs, much longer, the improvement was not as much and not clinically significant. Finally, Michael Schubert and I did a study where we used these headsets so they could do a gaze stabilization exercise at home once a day and still have and still be monitored and know that they would do it correctly. Only about half the patients did it one time or more, but of those, all of them got a clinically significant improvement. So what do we do here? So the gaze stabilization, for the study we did, we chose to focus on gaze stabilization exercises, which I like because the neurophysiology of it is well understood. We know that the dynamic vestibulo-ocular reflex function does not improve without therapy. Gaze stabilization improves dynamic visual acuity. And these also improve postural stability and are strongly correlated with improvements in dizziness handicap inventory. So I think if we're just going to do one exercise, this is probably the exercise to do. And so with that, I wanted to shift gears a little bit and look at, what about the otolith function? Is there a way to rehabilitate that? And that has not been looked at in nearly as great of detail. So in my laboratory, I thought about a couple ways we could try to do this, and both of them seem to work. So one is you just move people through an environment and offset the visual heading from the inertial heading, which I can do with these platforms and a screen. And so I'll test them before and find their headings near center. I have them experience headings that are offset by 20 degrees, for instance, then test them again afterwards, and their perception has changed. So we can adapt this fairly well. But I thought, and you do actually see some of this later if you have them come back a few days later as well. But I thought this isn't something very practical because people don't have $100,000 to put one of these motion platforms in their clinic. So we decided to also look at a virtual reality technique where we're actually having them in an environment that's rotating and they're like looking for the aliens from Space Invaders in this environment. And what we're surprised is you can actually, if you start rotating the environment slowly and have things appearing and disappearing in different areas, they don't really notice it, but you can adapt straight ahead with this. Now, I haven't tried this in patients yet. That's the focus of my current R1 grant, is to kind of get this worked out, a protocol for doing this, and then shift that over to patients to see if we can improve their function in some of these people with deviated headings and balanced symptoms. So in conclusion here, I think with vestibular physical therapy, poor compliance seems to be the major reason for failure. Only a couple of studies have looked at compliance, mine, which was about 50%, and another study which found it was even worse than that. I think patients do best if they work with a physical therapist or occupational therapist who's familiar with the techniques. Ideal dosing of exercises are unclear, but I think if they do it reliably once daily, they'll get benefits. Gaze stabilization is a good exercise. You have to have them move the head quickly enough for it to work. And finally, I think loss of otolith function may be a significant source of symptoms that's currently under-recognized. Thank you.
Thank you, Dr. Crane. I'm always impressed by your ability to sort of wrap your head, pardon the pun, around all this vestibular stuff. It's really amazing. So I'm going to go ahead and invite the rest of our panelists back on screen. We've had a few questions that have come through in the chat. So the first question I'm going to pose to Dr. Carlson. And there were a couple of questions that came in, and so I'm going to sort of lump them all into one conglomerated question around sort of counseling patients preoperatively around, sort of has your research changed what you counsel patients on? And second in that question is regarding headaches specifically and the migraine patients. Do you counsel them or manage them differently when they come in with that pre-op diagnosis?
It's a great question. The ultimate question is always, how does the research impact your clinical practice? For us, it's changed things significantly. Like, for example, if a person comes in with this particular baseline symptom, we don't tell them one treatment is going to be the thing that's going to be better for you. Like if they come in and they say, I don't care about anything else, my tinnitus is completely disabling, I need you to get rid of it. There's one study that I'm aware of that shows maybe surgery has a little bit of a benefit, but most of them say there's a wash, and our data says there's a wash. Same thing for a lot of the things. There is a lot of belief in our field and the neurosurgical field that if you come in with preoperative dizziness, if you come in with baseline dizziness, surgery is more likely to improve it. And I think that's a very specific subset of people with very clear unstable vestibular deficit, and you have to tease out vestibular migraine, all those other sorts of things if you're going to promise them that sort of outcome. But basically what they come in with, they're likely still going to struggle with at least to some degree afterwards. Also for headache, we don't necessarily steer some away from surgery and then a retrosigmoid craniotomy if they have bad headache. We are careful about counseling and also potentially preoperative evaluation by neurology and postoperative evaluation by neurology, depending on how bad their headaches are. So I think in that regard, it's changed a lot of how we counsel. We also are, along the lines of everybody else, we are more conservative with, at least with initial observation. We still treat a lot of people with surgery and a lot of people with radiosurgery at the Mayo Clinic. But increasingly more and more we observe, and it might not be that we think that they're ultimately going to always be observed, but there are some benefits to initial observation, even if you think they're going to get treatment. Like a 22-year-old patient with the tumor that's, a 22-year-old patient with the 1 centimeter tumor, they're going to need treatment at some point in their lifetime. I guarantee it. But giving them a little bit of time to think about it actually improves their quality of life. If their tumor grows fast, you pace it and you can inform your treatment. Like if it grew fast, you could do surgery, probably more likely than radiosurgery. You build trust with them. And then if you had a bad outcome from that treatment, which would be unlikely for a small tumor, but if you did, the patient would be more accepting of it because they knew that they had to have a treatment, then forego their option of observation. You can't take surgery back, you can't take radiosurgery back, but you can embark on observation initially. So there's a ton of things that this data, at least for us, have changed the way we counsel patients. We're actually more likely to observe slowly growing tumors, which, up until now, we say if it's grew 2 millimeters, you have to treat it right away. That's kind of dogma in a lot of places. We don't really use that. We're more flexible with it. We have a lot of data that says there's saltatory growth. They start, and stop. And maybe if you can maintain a baseline quality of life a little bit longer before they ultimately need a treatment that might decline their quality of life, give that time to them. There's no difference on a microsurgical outcome for a 1.2 versus a 1.4 centimeter tumor, period. So I just think there's a lot of stuff that this data helps inform and change. I could talk about this all day, but I don't want to take everyone else's time. But those are just a couple of the things I think have changed our way we think about patient management from this data.
That's great. Dr. O, there was a question for you about timing. And so if you have somebody who's coming in with a long-term paralysis, who's sort of multiple years, and now you've got some denervated muscle, how do you generally manage that? And then the corollary to that would be, do you ever treat patients sort of prophylactically if you know that the facial nerve is going to be at significant risk because of what it is that's being done?
Yeah, I think once you have long-term denervation, then no amount of new nerve input is going to reactivate that muscle because those motor end plates are gone by now. And so at that point, you really have to move to a local regional, like a temporalis muscle transfer or free muscle transfer. In the case of what you speak about, for example, there's a vestibular schwannoma that you've been following. And in one of the examples I showed, the patient was having mid-face paralysis and they were just sort of watching it. And we had 9 out of 10 otologists at a conference who all said they would wait because his eye was still closing. So his smile is gone on that side, but his eye was still closing. And that's sort of, I think, the traditional thing that in neurotology that people are looking at. But really, what about the smile? How important is that? And so in that case, we did a quick 5 to 7 transfer. The surgery takes about an hour, hour and a half, and you can rejuice that. Then if you want, you can continue to wait. If you start to get any other weakness, then you can also do a 12-7 as an end to side, so you can still preserve things, and you're not losing any tongue function because you're only using 30% of that nerve. Similarly, the other case with the woman who came for a re-resection, we went in and did a crossface because that's going to take 6, 9, 10 months to grow in. And in that time, you know, they've been observing, it's still growing bigger, it's growing bigger. And then when we go and do the actual resection with the 12-7, you have more of a chance of keeping that native musculature intact. So I think that's sort of been the new trend in facial nerve side, and I don't think it's always translated into the neurotology side.
Yeah. Well, I think it's a good example of why it's really important to have a multidisciplinary group managing these patients, not just, you know, multidisciplinary on the neurotology, neurosurgery, radiosurgery side,
Yes,
but certainly on the post-op side as well, because you guys are doing a lot of really cool stuff that you know, many of us are not necessarily seeing if we're not working with people who do a lot of facial nerve work. Dr. Crane, question for you about VEMP testing on patients and evaluating unilateral otolithic function. Any utility in doing that for these patients, and have you looked at VEMPs?
So the patients that I showed are people with a labyrinthectomy or unilateral tumor, have no VEMP function on the affected side. Now, clinically, we do see patients with vestibular neuritis, for instance, where the loss of function may be limited to the otoliths or maybe limited to the canals. So I think that type of testing can be helpful in figuring out where the lesion is. You can isolate it to the superior vestibular nerve, inferior vestibular nerve, canals, otoliths, etc. However, you know, how that affects what we do in therapy isn't really well defined yet, unfortunately.
Well, we have bumped up against our time limit, and I wanted to thank the panelists so much for their time on a Saturday afternoon to spend it with us. Again, thank you very much for coming. Thank you to the ANS for asking us to talk about quality of life for these patients, and we look forward to seeing you at the next session.
thank you.
Thanks, bye.
Sure.